Good morning. We just had a very interesting session on advanced imaging and what are the recent developments in this area. We covered 5 different modalities: echocardiography, coronary CT, cardiac MR, intravascular imaging and nuclear medicine. In echocardiography, there have been lots of new advances, more information coming out, including how to quantitate mitral regurgitation, what should be the severity in secondary mitral regurgitation for us to think that the prognosis is going to change. We talked about the role of global longitudinal strain versus measurement of ejection fraction in tracking cardiotoxicity, and we reviewed some of the new data showing the role of global longitudinal strain versus ejection fraction and how a recent randomized trial seems to cast some doubt on using GLS as the primary modality for tracking cardiotoxicity on cardioprotective therapy. We also talked about recent knowledge of the role of amyloid infiltration in the left atrium and how it creates a condition that is now being recognized of electromechanical dissociation, where the EKG shows sinus rhythm, but the atria do not seem to contract, and these patients seem to have high risk for total mortality as well as strokes. So, that is a entirely new field that is opening up. Then we also talked about cardiac CT. We talked about the role of photon counting CT, which is going to revolutionize how we look at coronary artery disease, since photon counting CT is very rich in information and will allow us to detect stenosis in coronary arteries with a lot of calcium and in coronary arteries that have stents. The first 2 papers have just come in this area and seem to be promising, but we need more data. We also talked about the role of subclinical atherosclerosis, whether in the form of coronary artery calcium or non-obstructive coronary artery disease, and the conclusion seems to be that any amount of coronary artery disease, whether in the form of coronary calcium or in the form of non-obstructive plaque, both seem to suggest adverse prognosis. We talked about a very new paper that says at what level of coronary calcium does the risk equal to patients who have had coronary artery disease, and it appears that 300 coronary calcium seems to make the risk similar to secondary prevention, and so that is why we may or may not have a concept of primary or secondary prevention anymore. These are not 2 distinct conditions, it is just a spectrum, and it appears that we should move away from primary and secondary prevention and just talk about presence or absence of coronary atherosclerosis, whether in the form of coronary calcium or non-obstructive plaque on CT, and treat these patients as though they have coronary artery disease, since the risk seems to be higher in people with coronary calcium, especially more than 300. We also talked about using CT as a gatekeeper to angiography and discussed a recent trial in the New England Journal of Medicine, which looked at patients going to either a CT pathway or invasive angiogram pathway, and it turns out that CT pathway seems to be safe in patients intended for coronary angiography without any adverse consequences, and with the advantage that you would have fewer non-intervenable lesions in patients going to the cath lab, and those who then go to the cath lab are very likely to have lesions that would need intervention, thus preventing wasted intervention. On the MR front, we talked about low field strength MR, which has the advantage of not needing extensive magnets with a lot of cooling, and so it is possible to have small MR machines that can be installed in areas which do not have the economic resources to have standard costly CMR machines. And we also talked about speedy protocols with limited views that could speed up the process of MR. Then we also talked about some artificial intelligence methods and mathematical modeling to allow gadolinium free MRs. And then lastly, on the nuclear medicine side, we talked about new tracers which are amyloid fibril specific, which would be better than traditional PYP scanning. And these include fluor beta PEAR, fluor beta PEN, and a new compound which is experimental but has just been translated into clinical practice in 2 papers that appeared this month, which seem to be amyloid specific, and they can do pan amyloid imaging and might help us quantitate amyloidosis, which is a big thing since these conditions need very costly therapeutics, and it might be good to know who are responders and non-responders. And lastly, in the intravascular imaging side, we talked about how plaques are modified by PCSK9, and it seems that PCSK9 therapies seem to increase fibrous scrap thickness and reduce lipid arc, and this might be one of the mechanisms for its benefit. So overall, lots of exciting things are coming in the field of cardiovascular imaging, and hopefully this will allow us to make better diagnosis and better therapeutics. Thank you.